This is the first in a four-part discussion on abdominal distension in neonates. And I'm starting with this slide out of respect to the woman who trained me, and since I will be alluding to her throughout this talk, I just wanted to briefly explain. This medical school was opened in 1952, and Dr. Catherine Poole was the sole pediatric radiologist here for about 20 years till she took her first colleague in the early 70s, and then I replaced him in 1977. She used to start many of her lectures with a statement similar to this. I'm not sure if it's really hers or if it was sort of taken from someone, but it's a very true statement, and I'm showing this out of respect to her. Neonatal abdominal distension, there are really very few causes for it. The most common causes are, the top three. Most often, it's extensive bowel distension due to functional disorders. And second most common is diffuse bowel distension due to intestinal ischemia, and I'm pretty much exclusively talking about necrotizing enterocolitis. Less common, but just as important, diffuse abdominal distension due to a distal intestinal obstruction, and this will be discussed. These other causes listed here, the only one that's frequent is if you have a large pneumoperitoneum, you can have an infant or a newborn presenting with abdominal distension. Large abdominal masses or bilateral flank masses, certainly less common, and the radiologist in this day and age has much less to offer in this regard because most of these babies are born with the diagnosis made on the basis of maternal ultrasound. This is a baby that obviously has severe edema of the chest and abdominal wall with central pooling of non-dilated small bowel loops, and you can see on the ultrasound a large amount of ascites. This is a classic hydrops fetalis, in this case due to ABO incompatibility. I should have prepared you for this. I have some very old slides of mine that, even though I kept them in plastic, developed fungus and grew hair or something over the years. I have no idea. But this is another patient with neonatal ascites. In this case, it was due to acute hepatic necrosis due to viral hepatitis. And just to point out that one of the findings on abdominal radiographs on the decubitus view, this is an LLD. You see the bowel loops floating into the upper right portion of the abdomen and centrally pooled on the supine film. This is another old slide, and just to tell you, I did try to clean these multiple times with slide cleaner, but this is still what you get. This is just another patient with neonatal ascites, and in this case, it's an erect film, and you can see the bowel loops floating in the upper half of the abdomen. When I first started here, we definitely did a lot of erect films, which we absolutely do not use in this day and age. This is a patient that has megacystis microcolon syndrome. You can see there's a mass effect extending from the left side of the abdomen. And believe it or not, this was just a hugely distended bladder, which is part of that syndrome. This is the same patient after a catheter has been placed in the bladder, and now you can see there are bowel loops occupying this area. And at the same time, we did at least a partial enema, and you can see the severe microcolon. But I'm just showing you basically as a patient with a huge bladder mass causing the entire abdomen to appear distended. Now, in this supine film, and this is the left lateral decubitus, you can see there's a mass effect in the right side of the abdomen, and although you really can't appreciate it, these bowel loops don't appear very lucent for having that much bowel gas, and that may always be a clue that you have some kind of mass compressing the bowel either from the front or from behind, and in a neonate, it's almost always a retroperitoneal mass. This is a patient that had bilateral multicystic dysplastic kidneys. It's unusual to have it bilaterally because it's pretty much incompatible with life. But you can see this is the right kidney and the left kidney and sagittal, and you can see bilateral large cysts pretty much replacing the renal parenchyma. This is the baby that you can see has a clear left-sided abdominal mass. And again, look at this loop of bowel. It should be much more loosened than that, so that's just a sign that, again, it's being either compressed from the front or from behind. And in a newborn, most neonatal abdominal masses, particularly large masses, are going to be involving the right or left kidney, so it's going to be a retroperitoneal mass. And in this case, there's either a second mass or this left-sided mass extends across the midline to the right side. This is actually, I don't think you can really tell it, but this is actually like a 1-minute film from an IVP. And back when I started here, believe it or not, we used to do 5, 6, 7, 8 IVPs in neonates a week because it was the only way to evaluate the kidneys or to evaluate whether you might have an abdominal mass, because ultrasound was truly in its infancy back then. On the lateral view, you can see there's that this right-sided component is actually compressing the bowel loops posteriorly. So it's a retroperitoneal mass on the left that's extending anteriorly across the midline. And just for completeness and also to let you know how far we've come, baby, this is what ultrasounds used to look like. It's probably only helpful in a lesion as large as this. This is the large left-sided component of the multicystic dysplastic kidney, and there's a smaller right-sided component to that same cystic lesion. His right kidney was normal. Again, looking at the supine film, you see a lot of air throughout the colon. It looks like colon, and it's like, why isn't it more loosened than that? Well, it's because the colon is being compressed because of bilateral retroperitoneal masses, and in this case, it's bilateral infantile polycystic kidneys. Because you can see that this is a 1 or 2 day old, and the right kidney measures 13 centimeters, which is probably 4 or 5 times the normal length it should be, and the left kidney has a similar length. And infantile polycystic kidney disease is probably a more common cause for bilateral flank mass than the previous case, which was bilateral multicystic dysplastic kidneys, which is a separate entity, again, usually unilateral. And the contralateral kidney, it may have hydronephrosis, but otherwise it should be a normal functioning kidney. And this is another patient that has a left-sided abdominal mass that in this case turned out to be a splenic angioma. Okay, anyone that sat with me reviewing films knows that one of my pet peeves is the importance of doing horizontal beam films in any patient that has abdominal distension or any symptom referable to the GI tract. And horizontal beam can be left lateral decubitus, which is always my preference, cross table lateral, and erect. And again, I'll show you a patient that I did erect back in the 70s, but it really has no usefulness anymore, and really you would probably kill any premature baby that you tried to hold up erect, especially the size preemies that we're getting in this day and age. But the importance of the left lateral decubitus film is not just free intraperitoneal air and to look for intraperitoneal air fluid levels. And I may as well say it right now. Intraluminal air fluid levels have a lot more significance in newborns and preemie growers than they do in infants or children or adults. The presence of air fluid levels other than in the stomach or the rectum points you in the direction that maybe you're dealing with a baby that has NEC or a baby that has a distal intestinal obstruction. But in addition to these two things, a supine film may not clearly demonstrate whether the baby has air in the rectum or not, and that's very important in assessing babies that may have a distal intestinal obstruction. It also can help you differentiate whether you're seeing transverse colon or descending colon, because it's very hard to differentiate colon from small bowel in newborns and preemie growers. It can help you differentiate stool from meconium because they can look exactly the same. And if you only have a supine film, you're stuck with having to say it could be either. Also important in patients with NEC is identification of fixed or persistent loops, also called the sentinel sign, which often is a sign of impending perforation if they haven't already perforated. And this last reason is more important for babies that have congenital upper intestinal obstruction, because you always need to know the size of the duodenum. And I will briefly discuss upper GI obstructions in the third part of this series. Okay, so large amount of air in the peritoneal cavity. The baby may simply present with a diffusely distended abdomen. One of the most important findings that I will demonstrate multiple examples of is the cupola sign. And that's air beneath the central tenon of the diaphragm, also referred to as the continuous diaphragm sign. Lucency over the liver, either an entirely lucent liver or partial lucent liver, is often a sign of a pneumoperitoneum in a supine baby. If it's a large pneumoperitoneum, you get the typical football sign with a falciform ligament, and I'll show you multiple examples of these. Regular sign is visualization of the mucosal and serosal surface of a loop of bowel. So you're seeing the entire wall inside and out, and I'll show you examples of that. Air beneath the diaphragm, more laterally. Air outlining the inferior edge of the liver. Air in the scrotum, and I'll show you examples of that. And then I'm going to briefly talk about avoiding confusion of a pneumoperitoneum with the normal retroperitoneal fat. Okay, these are two different chest x-rays, two different babies that obviously have a lucency. With this one you can see the falciform ligament, so he's got a football sign. This baby is rotated to the left, so there may be a falciform ligament over the spine, but it's always harder to see. Often the pediatric radiologist is the first person to realize that a newborn or a preemie grower has perforated, because clinically there may not be any definite, especially if it's not a huge pneumoperitoneum, there may not be any clinical signs pointing to the fact that the baby's perforated. The patient on your left here has sort of a globular heart with what looks like perihilar edema. This is the classic x-ray of a PDA, and those babies get some form of NSAID, an attempt to close the ductus. This is probably back in the days when they still use Indocin, and Indocin as well as ibuprofen, which is what they use now, at least as far as I've been told, can lead to perforation of the gastrointestinal tract, so-called spontaneous intestinal perforation, or SIP. It's not necrotizing enterocolitis. The baby has no clinical or laboratory findings pointing to necrotizing enterocolitis, and these babies obviously tend to do a lot better than a baby that has true NEC. And often they're treated with simply a peritoneal drain, and probably up to a half of them won't require any further surgical intervention. So these are probably both examples of so-called SIP, which is a fairly common cause for a spontaneous pneumoperitoneum, but probably less common than necrotizing enterocolitis, but both predominantly seen in premature babies. All right, well, clearly this is a huge pneumoperitoneum with the falciform ligament over the spine, because he is rotated to the left, so the falciform ligament is not going to be to the right of the spine like you would expect it in a baby that's not rotated. So this is the classic football sign, and in this case, it was due to a gastric perforation. I will show you a couple more gastric perforations that were related to the nasogastric tube perforating the stomach. That was not the case here. On the decubitus, you can see that there is a fluid level in the stomach, and technically this NG tube, even though it looks like it's projecting beyond the confines of the greater curvature, is probably just displacing the greater curvature slightly. Okay, this is another gastric perforation, and here's a regular NG tube, and that's the greater curvature of the stomach. And there's not much fluid in the stomach, because if you'll notice, this loop of bowel goes right up to it, so there can't be a lot of fluid in the stomach surrounding the air. So I wouldn't have suspected that this NG tube had perforated the stomach, but on the next radiograph, it's clear that this NG tube, again, it's a regular NG tube, not a replogal, has perforated the greater curvature of the stomach. And again, look on the decube. This is all there is to the stomach. There is no fluid in it. There's no fluid level. So it's a very contracted, air-filled stomach, and clearly this NG tube has perforated. This is a fluid level in the peritoneal cavity. And several decades ago, gastric perforation was probably almost always a result of just over-distension of the stomach. But over the years, with more judicious use of nasogastric tubes, that is much less of a cause. And I said the more recent cases we've had, several of them have been related to iatrogenic perforations. And I may as well say it now. Whenever you have an NG tube that's intersecting the greater curve at a perpendicular angle, especially if the stomach looks like it's being pushed down, it's not a bad idea to recommend that the tube be pulled back. Now, if you have a tube that follows the greater curve and sits in the antrum, that's exactly where they want it. And that kind of tube should not, over time, penetrate the gastric wall. But when you have it intersecting the greater curve at a 90-degree angle and it sits there for a period of time, it will eventually erode the stomach. So it's just another point of caution you might impart to our neonatology colleagues. All right, now here's air. This is the greater curve to the stomach, and you got bowel loops right against it. So there's not a lot of fluid around this gastric air bubble. So this is a replogal tube, and it is also perforated the stomach, causing a large pneumoperineum. Again, it's a football sign with a falciform ligament. I'll talk. This is a classic regular double wall sign where all of these, where you're seeing the serosal surface of the bowel. I mean, it's easy to see regulars on a decubitus view, but I'm going to show you several examples where you see regular sign on the supine view. This is a patient with a large pneumoperineum, also the football sign. There's the falciform ligament. The NG tube looks okay. This was not a gastric perforation. Here you can see regular sign. You're seeing the mucosal surface as well as the serosal surface of this loop of bowel. This is not because it's adjacent to a loop paralleling it. So that's regular sign. That's regular sign. And obviously you see regular sign where the pneumoperineum is layering out over the right side of the abdomen. Clearly in this patient you can see that the right lobe of the liver is just lucent. It's too lucent. Generally the density of the liver should be the same density as the muscles of the abdominal wall. You can see these are the muscles of the abdominal wall, and the liver is too lucent. So this obviously is a pneumoperineum, but the main thing I want you to understand is you can see this lucency, which is outlining the central tendon of the diaphragm. And if you saw that alone, that is what's referred to as cupola sign. And obviously the decubitus film confirms it. And I'm only stressing the appearance on a supine radiograph because I'm seeing it more and more that they're not doing supine and decube radiographs as the initial evaluation for a baby, whether it's for abdominal distension, vomiting, bilious or otherwise, not stooling, whatever the reason is you're assessing the abdomen. I think the initial radiograph should always include a decubitus film. And I'm going to show you a bunch of examples of a very subtle pneumoperineum that you just can't see on the supine film. Another patient, also a football sign, there's falciform ligament, and this shouldn't confuse you, but on the decubitus film, here's the falciform ligament. It's not uncommon for there to be a separate air collection that's anterior to the liver, which is where the falciform ligament lives, and this is actually another intraperitoneal fluid level against the falciform ligament. Most of the air and fluid is anterior and posterior to the liver that you see on this decubitus film. Another example of the same thing. This is actually the falciform ligament with a fluid level sitting against it, and this is more of the pneumoperineum caught anteriorly in front of the liver, and it's demarcated by the falciform ligament. Okay, this is what I was discussing earlier. This is actually the same baby at the same time, and he must have burped between these two radiographs because you can see the stomach got significantly smaller. But if his stomach wasn't so distended and I saw this replogal way down into the left lower quadrant, I would feel very strongly about telling the neonatologist that it really needs to be pulled back. All right? This was just a perforation. I think this was also considered to be a spontaneous intestinal perforation, or SIP. Because even though this is intersecting a 90-degree angle, it clearly has not perforated the stomach. But with time, especially if it's being pushed further under some degree of pressure, it will erode the gastric wall. All right, this is just a patient that on multiple radiographs had these very abnormal, and I will discuss this further in a moment, but he certainly has asymmetric bowel distension. He has too many elongated loops. Some of these have to be small bowel. They can't all be colon. In fact, none of them may be colon. And this was, I think, the next day. It looks very similar. And then the day after that last film was done, this was his radiograph, which again shows the entire liver is way too lucent. And by the way, something else you can compare the lucidity of the liver to is if you have normally aerated left lower lobe, the liver should also be denser than the heart. Because a heart with a normal left lower lobe should be, because of the air behind it, should be more lucent than the liver. But the abdominal wall musculature is the best thing to compare it to. And by the way, in this patient, there's air from the pneumoperineum extending into the right and left scrotum. Okay, this I think was a 9-day-old, 23-week-old baby that has multiple elongated loops, and most of these, or if not all of them, are going to be small bowel, and that's very abnormal. And this is the baby 20 hours later. And just to show you, even though there's not a lot of bowel, there's really very little bowel gas in the abdomen. On the decube, there's definitely a pneumoperineum, and I defy you to tell me where that lucency is on this radiograph. It happens to be sort of a crummy, grainy, supine view of the abdomen, but this is, again, the reason why you have to do a decubitus film every time. Because that's probably not more than this is a small baby, as I said. This may not be more than maybe a cc or so of free air. You think you ought to be able to see a small rounded bubble that corresponds to that, but you just can't see it. So this is why we need, I personally never fail to put in my impression on a case like, in a case where they only do a supine view, that recommend that follow-up films include a left lateral decubitus view. Okay, now this patient obviously has pneumatosis intestinalis. That's not why I'm really showing it. In fact, I'm going to be showing you the same case later as well. But it's because, all right, now this could actually be the posterior recess of the lung, of the pleural space. Maybe even it's a right pneumothorax. But here's a crescentic lucency that doesn't belong there. And also, if you look at this linear lucency right here, I don't think that's linear pneumatosis intestinalis because it doesn't look that way on the supine film. So these are just small collections of free air that I don't think you can even see on the supine view of the abdomen. Just to warn you, obviously this patient has, again, asymmetric bowel distension with probably multiple loops of elongated dilated small bowel. He's got pneumatosis in the right flank. But just be careful. Just because the technologist labels it left lateral decubitus doesn't mean it is. You can tell by the fluid level in the stomach it's really a right lateral decubitus. And a small amount of free air when you do a right lateral decubitus, and you also happen to have a lot of distension and air-filled bowel against the left abdominal wall, you can miss a pneumoperineum. That's why it has to be done with the left side down. And if the technologist has done it incorrectly, it really should be repeated. This is that same baby 24 hours later. And I don't know if you could argue if there's a vague lucency over the mid portion of the liver right here. That would probably be an overcall if I said that. Here's the pneumatosis. It's actually better than on the prior radiograph. But look at this pneumoperitoneum that you see on the decube pretty much only, because again, even in retrospect, I can't see it on the supine film. I don't see a double wall sign anywhere. That amount of free air could have actually been on that previous decube done the day prior, but was missed because it was the wrong decubitus view. So it's critical that the correct view be done. All right, now here's a 500-gram baby, first day of life. It's just part of umbilical, arterial, and venous catheter placement. But if you'll notice, there's a lucency here. This is not a rib. You can see it's separate from the rib. There's a lucency. This is the cupula sign. It should not be confused with stomach bubble because you can see he has a relatively gasless abdomen. You would never have air in the fundus of the stomach to that degree on a supine radiograph. Obviously air in the supine position should rise to the body and antrum of the stomach. So this should never be confused with a loop of bowel or the stomach bubble in particular. I will show you a case later that you have a loop of bowel that sort of is giving you a pseudo cupula sign, but not this one. So 4 days later, this baby had a repeat radiograph. This just shows you some preemies are just sort of indestructible. He had a pneumoperitoneum 4 days before, and here he is 4 days late. And here he is, and you can see a small amount of free air over the right lobe of the liver. This is a very funny-looking loop of bowel. I mean, it could be extraluminal air, but this pneumoperitoneum right here, again, I do not see it on the supine radiograph. He doesn't have a cupula sign anymore. So again, you've got to do a decubitus film. This is another patient. This is cupula sign. Should not, if you notice, there's not a whole lot of air in the stomach at all. And even if there was, this should not be confused with air in the fundus of the stomach. You could argue again, is there some slight lucency over this portion of the liver? That's tough to say, but the decubitus shows the free air the best. And he obviously has a very abnormal loop of bowel with a large air fluid level within it. This is another patient with the cupula sign. But it's clear here that you have lucency extending over most of the right lobe of the liver. So it shouldn't be confused, but this is the most important thing to look for. And I'll show you a cross-table lateral view that will explain why that's true. He probably has a regular double wall sign in multiple areas. You can certainly see it on the DQ. Okay, these are two different patients, cross-table lateral views. This is a neonate that doesn't have a lot of bowel gas, and this is one that has bowel gas everywhere. But even when you have a lot of diffuse bowel distension, this portion of the peritoneal cavity is the most anterior. So that is where free air will collect first on a cross-table lateral. And I may as well tell you right now, I'm not horribly fond of cross-table laterals, but it's absolutely clear, and the neonatologist will tell you every time, there are just some premature infants that don't tolerate being put on their left side, especially if they still have lung disease, especially if they're on a ventilator. So it's hard to force the issue if they really tell you that the baby could all of a sudden deteriorate just by changing their position. So doing a cross-table lateral for free air is more than adequate, but I will just caution you this. Just to be 100% sure, it's not a bad idea to try and put the baby in a slight reverse Trendelenburg position. In other words, just build them up slightly so you're sure that their chest is slightly higher than their abdomen. These later babies are laying totally flat, and even totally flat, that's probably good enough. This is just another example. Again, there's probably lucency extending over the right lobe of the liver, but here's the cupula sign. Again, this is the air in the stomach way down here. And in this case, you're actually outlining the entire inferior surface of the whole left lobe of the diaphragm. Well, this is a really important case because this is the case that we missed. They only did a supine film of this baby because of abdominal distension, and it was read as a right inguinal hernia. But if you look at this film, there's clearly Wriggler's sign pretty much everywhere. This is Wriggler, that's Wriggler, that's Wriggler, that's Wriggler. But the most important thing, again, is there's the cupula sign. Here's the gastric air bubble down here. This is free air beneath the central tendon of the diaphragm. And it's absolutely common for a pneumoperitoneum to dissect into the scrotum, often both sides. In fact, it is on both sides. And this next slide, the left slide is that same baby. But this is a different baby with a huge pneumoperitoneum and air in both the right and left scrotum. This is a pretty dramatic case of Wriggler sign that it just goes to show you that even we should get decubitus films to be 100% sure. And the next two slides are actually that same baby on the left, the follow-up radiograph, which has a decube with it, but here you see the cupula sign again. You see the Wriggler's double wall sign. And there's regulars again in multiple places, but clearly the decubitus is always the best. And this, again, it's important to impart this to our neonatal colleagues, because at 1 or 2 in the morning, this is the best view for them to prove. You don't want to have the diagnosis of free air delayed for 5, 6, 7, 8 hours, because the baby may continue to deteriorate if that happens. This is a pseudo cupula sign. All right. Generally you don't have bowel loops overlying the liver, and you don't have bowel loops extending higher than the stomach. But if you have diffuse bowel distension, both of those things can happen. So this is actually a loop of bowel and should not be confused with a cupola sign. And the decubitus sort of proves it. See, this is that loop of bowel. This is stomach bubble with a big fluid level in it. And there really is no pneumoperitoneum. He happens to have portal venous air. He obviously has pneumatosis intestinalis. He obviously has asymmetric bowel distension with a bunch of elongated loops of small bowel. But fortunately, most of the time, bowel does not usually overlie the liver, nor should it extend up above the level of the stomach. Because again, I've shown you exactly what's stomach here. So stomach obviously can go to the diaphragm, and generally you don't see small bowel loops extending up to the level of the central tendon of the diaphragm. This is a supine and decubitus on the same patient. Older patient has got a G-tube. Here's Wriggler sign. This is Wriggler sign. Double wall sign. This is Wriggler sign. This is Wriggler sign. It's everywhere. And this lucency right here is extremely unusual for dilated bowel loops to compress an adjacent loop into a triangle like that. It just doesn't usually happen. So I think this is loculated air that's caught beneath the inferior surface, the inferior edge of the right lobe of the liver. Didn't change at all in the decubitus. And here's a smaller amount of free air that you've seen extending over the right. I mean, again, you had a hint of it right here, but it's just more obvious on the decubitus film. Sort of an unusual case, but here's a baby that obviously has cystic and linear, curvilinear pneumatosis in the right flank. Also, the splenic flexure has bowel wall edema. And on the decubitus film, again, you have this peculiar lucency, and bowel loops, again, should never compress adjacent bowel loops and give. So this is a loculated pneumoperitoneum, and that's exactly what they found at surgery. Sometimes this is a supine film with sort of a paucity of bowel gas, but maybe some minimally distended, elongated loops of small bowel in the lower abdomen. But on the decubitus film, you have this peculiar lucency of the liver. Well, you know that's not bowel gas. It's not giving you that nice presentic lucency like you'd like, but most surgeons will accept the fact that, especially if you have a supine film that correlates with it, that has to be extraluminal air. Now, this is a bizarre case that I had, from the late 70s, early 80s. I led these slides to a pediatric surgeon, and instead of giving me the originals back, he made copies, kept the original, gave me the copies back, and then wrote on them with a fountain pen. No radiologist in the world, if I was going to label an x-ray, I just use a soft lead pencil. So that's why this looks so bizarre. This is actually, it says S, but the supine film in this baby looked just like this. You have these unusual lucencies over the right lobe of the liver. Didn't change, this is the decube, didn't change on the decubitus, looked exactly the same. And the surgeons were not, this is questionable whether there's, extraluminal air against the tip of the liver. I went upstairs and I held the baby upright for about maybe 30 seconds, and you can see clearly that the air moved under the right diaphragm. Now, I would never, ever, ever do this again in the age group that we're dealing with. If you try and hold a very low birth weight baby upright, you'll probably kill him. But I'm just showing that this was probably a 1,700, 1,800, 1,900 gram baby, and he didn't have much lung disease, and he certainly wasn't intubated. So he tolerated me doing that, but I was determined to prove to the surgeons that the baby was indeed perforated. This is another old case, just to show you what free air looks like on the cross-table lateral. This is the edge of the liver. it's a lousy old film with a lot of pneumatosis on the right side. And you can sort of see the abdominal wall musculature, that it's denser than the liver. So, this shows clearly that there's air sitting in front of the liver, but the cross-table lateral just sort of confirms it. This is a baby we had recently that I think he was 3 days old, and he just had sudden onset of abdominal distension, and the X-ray showed a massive pneumoperitoneum. And they stuck a drain in this baby, and this is about 12 hours after they put the drain in, and he still had a significant pneumoperitoneum. This is the cupula sign. But I mainly show it because, again, it's an example of what free air in front of the liver looks like on a cross-table lateral. Okay, I just wanted to say a few words briefly about properitoneal fat. It's not something that should confuse us, but sometimes it's sort of a confusing finding to our clinical colleagues. This is properitoneal fat right here, okay? And the reason why on the supine film you may not see much, whereas on the decube you see it more dramatically, is in the supine position I sort of consider the fact that the liver is compressing that fat. And again, properitoneal fat is the fat, if you look at the layers of the abdominal wall going from inner to outer, you have the viscera, i.e. the liver, the visceral peritoneum, the peritoneal space, then the parietal peritoneum, and then superficial, to the parietal peritoneum is the properitoneal fat. And that properitoneal fat is directly continuous with the perirenal fascia posteriorly. So one reason also why the properitoneal fat may be more dramatic on the decubitus is because the liver falls away from the abdominal wall, so the fat isn't compressed as much. Plus, if the baby happens to be rotated, and you can see significantly rotated to the left on this decubitus film, that means you're seeing the more posterior part of that fat layer, and it is wider because it gets wider as it approaches the perirenal fat. I actually got called in very early in my time here because they thought that was a pneumoperitoneum because you saw it on the decube and not on the supine. But that mistake really shouldn't be made because it's really not loosened enough to be free air. Another example is the same thing. Here the baby's supine, and this is the properitoneal fat. And you don't have to see it all the way down. You may not, as in the last case, you may not see it at all. But then on the decubitus film, which isn't very rotated, it's just more dramatic because the liver is now fallen away from the abdominal wall and it's not as compressed. He's turned a little bit to the left, but not much. And by the way, don't get concerned when you see this. These are two different fluid levels, but they both happen to be in the stomach. It's not unusual for it to get caught in the fundus and proximal body, and then have a secondary fluid level in the distal body and antrum. Should not be confused with a fluid level in another loop of bowel, because clearly here he doesn't have a dilated loop. This is transverse colon in this particular case with visualization of meconium. An even more dramatic example, this is a baby with NEC that developed a fixed loop, and these are two different decubitus films pretty much a day apart. And if you'll notice, on this decubitus film he's turned to the right, and on this decubitus film he's turned to the left. And when you turn to the right, the properitoneal fat will be thinner, and when you're turned way to the left, the properitoneal fat will be wider or thicker, if you will. There is no evidence of a pneumoperitoneum on this patient. And these are horrible slides because they're old slides, but just to remind you, we don't see it that much anymore, but there's no reason why it can't happen. Usually 99.9% of the times a pneumoperitoneum implies a perforated viscus. But back in the old days when barotrauma was much more common with our patients, if you ever had a patient that had a posterior pneumomediastinum, and that's what you're seeing here, is this lucency that sort of tapers as you get to the esophagogastric junction, and there actually is a tubular filling defect in the middle of it that's water density. That's actually the collapsed esophagus. This is a posterior pneumomediastinum. And although this is a different patient, he also has that sort of oval lucency that comes to a point. That's also air in the posterior mediastinum, and air in the posterior mediastinum can dissect into the retroperitoneum and very quickly rupture into the peritoneal cavity, and so you can have a pneumoperineum that's benign and unrelated to a perforated discus. If you have a sick baby that also happens to look like they may have a GI disease, it may be hard to differentiate the two. If you do a decubitus film in a baby with a pneumoperitoneum and a posterior pneumomediastinum, and you demonstrate an intraperitoneal fluid level, not intraluminal, but intraperitoneal, it has to be a perforated discus, because a pneumoperitoneum that's from dissection of a pneumomediastinum should never give you an intraperitoneal fluid level. There should be no bleeding associated with that. Okay, now I'm going to spend some time talking about the normal neonatal abdomen, and these are the kind of things that you need to look for. Generally, normal neonates have air throughout small and large bowel. Small bowel loops should always be seen end-on, should not be seen lengthwise. And I've already said it can be difficult to differentiate an elongated loop that's colon versus an elongated loop that's small bowel. Because if you can prove it's colon, it's not important. Generally in newborns, especially preemies, you don't have hostrations in the colon. We do plenty of enemas in that age group, and even when you do an enema, you often don't see hostrations in the colon. This is a very true statement and can be very important. A meconium pattern, in other words, what looks like meconium in the colon, is very common in term babies, but it's extremely unusual in premature babies in the first week of life. I'm not even sure about the reason for that, but it's a very reproducible finding. So if you have a premature baby that's 2, 3, 4 days old and you see what you think could be meconium, always favor it being pneumatosis. Sigmoid colon goes to the right, and I'll show you examples of that. There should be no air fluid levels in the abdomen, whether it's a normal abdomen or a baby with so-called non-specific distension. The only fluid levels that are acceptable are in the stomach, and for some reason you can see fluid levels in the rectum all the time, and they usually have absolutely no significance. And I've already said, usually you do not see bowel loops overlying the liver unless you have extreme diffuse distension of the GI tract, and I've already talked about the density of the liver. Okay, one of the residents that was on the rotation recently asked me how you decide if a loop of small bowel is dilated or not. Well, I think this is the only study that attempted to answer that question by Dr. Edwards, from 1980. Either of these measurements are probably adequate. You don't have to do both. Trust me, I don't think there's a pediatric radiologist in the world that does these measurements. But if you want an answer to that question, this is it. LD is the transverse diameter of the loop of small bowel that you're concerned about. So you can either measure from the upper border of of L1 to the lower border of L2, and the transverse diameter of the small bowel divided by that distance should be less than 0.7. And you get a similar relationship if you take L1 measuring from the lateral aspect of the pedicle to the lateral aspect of the opposite pedicle. The transverse diameter of a loop of bowel that you're concerned may be dilated should be less than 0.7, same measurement. So I've said it. If you want to try and use it, more power to you, but I guarantee you that there's probably not a pediatric radiologist alive that actually measures. It's really, unfortunately, more of a gestalt. Okay, this is a baby that has distension, and he has these funny-looking lucencies, but if you notice on the decube, it looks like it changes. It looks like it layers out. Well, that proves it's meconium. So again, that's one of the advantages of doing the decube, other than the typical things that I mentioned earlier. And I showed you this case earlier. This was also a term baby, mottled lucencies, looks the same on the decubitus. If it's a term baby, you can pretty say he had no follow-up films. He had no symptoms, and I already talked about his 2 fluid levels. So you can see meconium in the colon the minute air hits the colon in term babies, but it's not a finding you should see in premature babies in the first several days or even the first week of life. Not as good an example. In fact, this decube is horrible because it's too grainy, plus the sheets they're laying the baby on are covering the area. But mottled lucencies in the area of the splenic flexure, maybe less so on the right side. Pretty safe, and there's no abnormal distension, by the way. So it's pretty safe to conclude that it's normal meconium. This is not a very good example. It doesn't project well, but also probably has some mottled lucencies in the area of the splenic flexure. Now, this is a case we had recently, and this is not the way it usually is going to look. This was, I think, a 37-weeker. He has these mottled lucencies. These are two different supine films done hours apart. It was basically for the umbilical vein catheter placement. And very unusual, but you can say with certainty that this entire loop is absolutely colon. You often can't say that, but in this particular case, on both supine views done really minutes or no more than 10 minutes apart, you can clearly say this entire loop of dilated bowel is colon, because if any of that was small bowel, it would be extremely abnormal. Well, again, this is a copy of an old case of mine. You can tell by the crap on it. But mottled lucencies in the area of the splenic flexure, and 18 hours later, they're gone. Just to show you that, especially if it's a term baby, sometimes you can sort of get the impression you can see haustra. So, yeah, this is an elongated loop of bowel, and it's certainly adjacent to the greater curvature of the stomach. But in this particular case, I think you can be safe saying that it's colon, because I actually do think you're seeing haustrations. But usually you don't have that option. This is another patient. Again, this is sort of a dilated loop of bowel, but that looks like a haustration, so it also is probably normal. You don't need to worry that that's dilated small bowel. Okay, and this is the problem if you only do a supine. This is supine on left lower decubitus, but an elongated dilated loop of bowel transversely across the lower abdomen often is just the sigmoid colon. And what the decubitus view will do is prove that it's the sigmoid colon. This is sigmoid colon going to the right and then descending down into rectal air. The sigmoid colon generally does go to the right in newborns and preemie growers, and it should not be a cause for concern, but again, you often will need the decubitus to prove that. Another patient, same thing. It's like, what is this asymmetrically dilated loop of bowel seen lengthwise in the right lower quadrant? Well, I think the decube pretty much proves this, probably the sigmoid colon. And I'll show you a more dramatic example of that in the next one or two slides. So it shouldn't, and again, there's a fluid level in this rectum. It shouldn't confuse you. Well, again, this is kind of an awful X-ray because it's just so grainy. But, there is a more dilated loop of bowel seen in the right lower quadrant, which on the decube pretty much has to be the sigmoid because of a lot of that air that has now risen into the rectum. So this is a relatively nonspecific gas pattern. Now this is the supine and decube on the same patient, and it's like, is this all colon where I sort of see a continuous loop here and a continuous loop here and a continuous loop here? I'm even amazed by this case because look what happened on the decube. All of that air that was in the transverse and descending colon seems to have moved over to the sigmoid and rectum. So it absolutely clears the path for calling this a relatively normal gas pattern, which I may not have been willing to say on the basis of the supine film alone. And this is just another recent case. And when I first saw this, I thought, boy, some of that is going to be a very dilated loop of small bowel. But I was totally wrong because on the decubitus, you can see that you definitely have some air that rises in there. So some of that is sigmoid colon, although some of these loops on the left side are a little bit concerning. But then the next day, the baby looks completely normal. There's no distended bowel. So that was just a normal, and just because you happen to see a distended rectosigmoid colon doesn't mean you need to get hysterical and worry about Hirschsprungs. This is a similar example of the same thing. You have this loop that you think is going to be transverse colon because it's paralleling. This is all stomach with a peristaltic wave. You think it's transverse colon, but you can't always be sure. You think this is descending colon, but you can't, and this may be sigmoid, but you can't always be sure. Well, look what happened on the decube. Both of those loops disappeared, and the only way they could have disappeared is by the air extending up into the ascending colon. So the decubitus, as I stated on that earlier slide, the decubitus may clear the issue of what bowel loops you're looking at. It may just be simple normal caliber colon. Because again, if this was small bowel or if this was small bowel, it would be extremely abnormal, even if it didn't have an air fluid level in it. Okay, so I'm just going to show you. I have to apologize, but my philosophy about trying to teach residents about what's abnormal is show you a bunch of examples of both. Because if I show you a classic example, it's just not going to mean anything. So these are just normal abdominal radiographs. All the small bowel loops are sort of seen end on. None of them are dilated, so-called honeycomb or mosaic pattern. Same thing here, a little bit more distended, but still not pathologically dilated. It's a normal, non-specific gas pattern. It's not dilated at all. In fact, usually when we say non-specific, we're saying non-specific distension. This is like no distension at all. Another patient, same thing, normal gas pattern. No real small bowel loops seen lengthwise. No bowel loops are dilated. Another patient, same thing, normal gas pattern. And just one caveat about bowel loops being seen over the liver. There's these funny lucencies over the right lobe of the liver. Whenever you see that, the most common reason to have bowel loops in this area in our population is a baby that's had a left lobe liver transplant. But this is only a baby that's a couple months old. So always go back and see if there are prior radiographs. And notice this baby had a huge omphalocele. Omphaloceles are allowed to have air wherever they want once they're closed. And just to make that point even more, not only does bowel and liver get to go wherever it wants to go when they close the omphalocele, the duodenum will migrate. So this is I don't know where exactly the pylorus is, whether it's here or here, but when the liver is not sitting in its normal position in the right upper quadrant, which it often isn't in an omphalocele patient, the retroperitoneal structures will move. The liver, the right kidney will move higher, and even the duodenum, even though it's a retroperitoneal structure, will also migrate. So you don't need to get hysterical about where the heck is this tube going? Why is it completely out the confines of the normal position of the C loop? Okay. Briefly, I'm going to talk about symmetric or non-specific distension where the bowel loops are pathologically dilated, but they're again seen in the mosaic or honeycomb pattern. No small bowel loops seen lengthwise. No asymmetry of the bowel pattern. And I should have put here no air fluid levels as well. And asymmetric distension I'll start in the next section. Okay, maybe he's a little bit more dilated than the previous ones I showed you. But again, most of the bowel loops, the small bowel loops are seen end on. All the loops are about the same size. So this is mild nonspecific bowel distension. That does not mean the baby might not go on and develop necrotizing enterocolitis, but it's certainly less concerning. And if there are no clinical or laboratory findings pointing to that, they might just do a follow-up film, or if the baby seems to be doing well clinically, they'll just leave it at that. Again, very mild, nonspecific bowel distension. Same thing, maybe a little bit worse. Again, I don't see any small bowel loops lengthwise. I don't see any air fluid levels. Maybe a little bit worse of the same thing. I mean, there's some elongated loops, but probably they're going to be colon, although I told you, be careful if you make that assumption. Some people might have called this, maybe slightly asymmetric, do a follow-up film. Again, relatively normal. Everything's sort of the same size. No air fluid levels on the decube. Maybe a little bit more distended. The decube is really unimpressive. This is going to be colon, rectum. Maybe a little bit worse, but, this is maybe a little bit more equivocal. It's like, here's a loop that's slightly elongated, so I wouldn't argue if someone asked for a follow-up on this, but to me it's relatively nonspecific distension. You'll get a better idea of what's asymmetric distension when I start showing you the babies that do have NEC or do have a distal intestinal obstruction. Again, this one might be a little bit more equivocal, or some of these loops seen lengthwise, and they're not really in the position of the colon. But I wouldn't argue reading mild nonspecific distension on that case. And the same thing here. Maybe there's some elongated, minimally dilated small bowel loops, but generally an unimpressive abdomen. And I'm only showing this case. This is certainly not asymmetric distension. There's some elongated small bowel loops here. In fact, all of these might be small bowel. And this is the same baby less than 24 hours later, where he's improved significantly. And I'm only showing you this case because there are many causes for nonspecific bowel distension, especially in premature babies. There used to be a term that I don't think is used anymore called functional ileus of the premature, and it's got multiple underlying causes, electrolyte disturbances, sepsis, and this is a sort of a unique cause, at least in our institution. This was a baby that was referred from an outside hospital because he was developing, or they were concerned he was developing retinopathy of the premature. So these babies often get referred to be evaluated at Bascom-Palmer. And believe it or not, the mydriatic that they give to these babies to dilate their pupils can cause significant paralysis of the GI tract for 12 to 24 hours after its administration. And that's what this baby had. And I'll tell you, I've seen several cases, and it gives you the worst amount of distension I've seen. That's technically on a functional basis, because you've actually paralyzed the entire GI tract. They didn't do a decube. I'm not sure whether he would have had air fluid levels or not. But they certainly have to decompress it, and you can see they have partially accomplished that. So that's just another bizarre cause for functional bowel dilatation that's, again, sort of unique to our population because of the importance of referring these kids for adequate ophthalmologic examination.